Okay, so first I am going to have you step over here to take your height. Go ahead, back to the thing, and then I am going to go ahead and pull it down, okay? There you go. Top of your head? Did it touch the top of your head?
Yes.
Awesome. Let me just notate that here. There you go. I'm going to lift it up there. And then I am going to also, you can go ahead and step off of that. I'm going to also have you step onto the scale as well. When you're ready. There you go. Okay, you can go ahead and step off there. And then you can go ahead and sit down right there. I am going to go ahead and get your neck circumference. So I'm going to come behind right here. And I am going to get the neck circumference. And then I am going to move your hair, okay? There you go. Let me see. So that is 16. So
16?
yeah, 16 inches.
All right.
That means you could tell that to your tailor.
That's great.
16 inches. There you go. And then last but not least, I am going to go ahead and take your blood pressure.
Okay, so Dr. G, I want to know, when you're at home, does your wife or significant other ever mention if you stop breathing throughout the night?
Yes.
Okay. Do you ever feel like you wake up with like a cold sweat or like sweaty palms?
No.
No, okay, good. Do you ever feel like you wake up in the middle of the night to use the restroom maybe multiple times throughout the night?
Yes, absolutely.
Okay.
At least seven times a night, I get up and go to the restroom.
I see. Does your
I've been
significant...
checked for prostate, and I have no prostate problem.
Okay, wonderful, wonderful. Does your significant other ever like wake you up and just like I can't stay in the same room with you because of your loud snoring?
Well, she's being polite, but she's told me that it's no.
Got it. Okay.
And so I excuse myself out of the bedroom.
I understand. Throughout the day, do you ever feel like you are tired even though you give yourself ample opportunity over 8 hours to sleep? We always are concerned about a condition called sleep apnea. Have you heard about it before?
Yes.
Okay. What do you know about it, just so we can have a baseline?
The sleep apnea, I just know that it's basically when you gasp for air and whenever you're snoring, you're not getting enough oxygen, so it affects all these different things.
Yes, so that is true. A lot of times patients, when they think about sleep apnea, they're thinking about this mask that is connected to a machine that's always plugged in. So that is true, that's one way of treating sleep apnea, but now with modern technologies, even with AI, we're able to create a customized oral appliance, an appliance similar to like a mouth guard or sports guard that you can wear, you can travel with, and it allows you better sleep, quality of life, and not be fixated on such a machine that I've seen many patients cannot tolerate. Okay. What I want to do for you today, I want to go ahead and do an examination. So I'm also a dentist by nature, so I'm going to look at all your teeth, look inside your mouth, and give you my best recommendation whether I suspect you have sleep apnea or not. How does that sound?
Sounds good.
Okay, wonderful. Do it is just for educational purposes. I'm going to go ahead and kind of say exactly what I'm looking for so you have an idea of what I'm reviewing. Okay?
Right.
So right now, what we're going to do, part of my examination is going to be the sleep bang. So a lot of the sleep bang information is gathered from the patient. It has to do with their BMI, their gender. So a lot of times you'll check yes if the BMI is over 25. You'll check yes if you're male. You'll check yes if your age is over 50. Those are the most common types of patients that are of high risk of having sleep apnea. But at the same time, we don't want to just rely on the stopping altogether, because then you neglect on the patients that might have a genetic precursor. So a young, petite female that has been having trouble sleeping, you don't want to just disregard them because assuming it has to do with stress or fatigue, because at the end of the day, genetics has a big factor. Your tongue size, you get that from your mom and dad. You have no control over that. So even if you lose weight, tongue is not going to change. Your tonsils are not going to change. So that way we don't push any patients away. Okay, say open please. Stick out your tongue. Say ah for 3 seconds please. Wonderful, you can go ahead and relax. So the next thing I look for is, since you're already focusing on the tongue, you're looking at tongue size. So it's called tongue level. You have 1, 2, 3. It has to do with your tongue relative to your occlusal plane. So whenever you have them open, just have them kind of swallow so that their tongue resets and relaxes. And then you see where the position is. Level 1 is when the tongue is below the occlusal plane and you can kind of see all the occlusal features of the teeth. Level 2 is at the same level, and then level 3 is when it sits over. Our concerns are at level 2 and 3. Although if you determine it to be level 1, don't disregard that, because at the end of the day, we're looking at him in a position where he's upright. But when you're sleeping, you're laying back, so the tongue will shift. Okay? Go ahead and open for me. And then close. Go ahead and swallow, and then open. So tongue level is a 3. And now when you're looking at tongue, stick your tongue out one more time. When you're looking at a tongue, you're also looking at the borders of the tongue. Scallop borders are usually a clear indicator of the tongue size relative to their mouth. If you see scallop borders, that usually means that the tongue in its natural position is pushing against the walls of the teeth. That's what's creating the scallopness. Although it's not a pathology, it is just one way we identify and represent that the tongue is of large size. Macroglossia is by definition the name. If you see erythematous,
big tongue.
Big tongue.
Yeah.
If
So I have a big tongue.
Yes. When you're looking at a tongue level, you're also looking for erythematous, red areas, or white lesions that usually kind of indicates larger tongue size. It's one of the check marks that we do on our questionnaire forms. All right, go ahead and open. Next thing you're looking for is, I like to look at the buccal mucosa. So when I'm looking at the buccal mucosa, if I see typically it's like a white lesion, it's more of trauma. It gives us the impression that their mouth size relative to the teeth is small if you see it. So then you ask the patient, oh, do you feel like you bite your cheeks often, your lips and tongue? Typically they would say yes, or if they're not aware of it, it's something that they do when they're sleeping. So when I'm looking at a patient's teeth, I'm looking for occlusal wear, incisal wear. I'm looking for cupping on the posteriors. Typically as general dentists, when you see that, you immediately recommend a occlusal guard. If you see a lot of crowns, then you start asking questions like, oh, I see that you have a lot of crowns. Did the teeth break or fracture? Those kind of indicate heavy clenching, grinding, and wear. The best patients that you'll see are the patients who don't realize that they're clenching or grinding. Then you bring it up to their attention. It's something that's subconscious, unconscious when they're asleep. I like to tell patients that there is a correlation from clenching and grinding with sleep apnea. Reason being is because when you're sleeping, your body is very resilient. It realizes that you're not breathing enough, so it moves its jaw left and right to ever so slightly open up that airway. And that's one of those things that we notice with sleep apnea patients. Another thing is, with addressing sleep apnea with the appliance, we address the clenching and grinding because now you're addressing the etiology. If the etiology isn't directly correlated to sleep apnea, the sleep appliance acts as the mouth guard as well. So it addresses the clench and grind no matter which direction it goes or which avenue. Okay, all right, so go ahead and open. So that's what we see. We see clench, we see wear of the teeth. We also see buccal abfractions. If you're not aware, buccal abfractions are caused because that's the middle of the tooth, so that's where there's most flexion. So then the enamel portion of the teeth starts chipping away, and the way you know it's an abfraction is because when you touch it with Explorer, it's not due to caries. So that's something I commonly see. Next thing I look for is, open please. I look at the roof of the mouth, the hard palate and soft palate. The reason being is because when we make these customized appliances, you don't want the soft tissue to be loose. It affects the retention and resistance of the devices. So that way, when we're looking at this, we're trying to figure out, are they a good candidate for the device or not? You also want to make sure that they have enough teeth to support it. From my experience, a lot of times if they have a little bit of crowding, the best approach is a more softer sleep appliance, so that way it flexes to the undercuts of the teeth. If they have perfectly straight teeth, they can choose whichever device that we offer. Okay, all right. go.
So you saw the signs of bruxism.
Yes, sir.
Yeah, I do grind my teeth.
And the thing about bruxism is you may have done it in the past, but now that you're treating it, every time you see a new dentist, they're always going to see and make note of it. But so long as you're taking care of it, we just don't want it to get worse. We want to at least maintain stability. There's not much you can do beyond that, so we just want to make sure the teeth don't break or fracture. Okay. All right. The next thing I usually look for is I want to ask my patients, when you sleep or throughout the day when you're breathing, do you feel like you breathe through your nose or through your mouth? You have to think about both of them. Okay, good. Whenever they say both, or typically they'll say the nose, then I look at the nose positioning. I want to make sure that there's no deviated septum. I want to make sure that they have proper airflow, because at the end of the day, if they're a nose breather or even a mouth breather. But mouth breathers are a little more troublesome because when you have such a bulky device, it affects their sleep.
Good. Do you see a deviated nasal septum?
So airway is relatively clear. I wouldn't say the deviated septum, but do you notice that there's slight elevation on your right?
Yeah, I actually do have.
Did you have surgery?
No.
Okay.
I was told.
So we're gonna go ahead and determine his breathing. So go ahead and blow. Okay. And we're gonna do it on the other side. Go ahead and blow. A little more resistance on the left side.
Correct.
Yes.
And you are right, doctor. I have a deviated nasal septum, and my left nostril, there's less airflow.
All right. So that's something to look at and to consider as part of our treatment planning is to fill it out. Then you look internally, make sure there's no congestion. Sometimes you can ask patients if they have frequent sinus infections. And so that way, with a proper panel, we can properly evaluate that. Those are just the things we look at for airway, okay?
Cool.
Next thing I like to do is, as you're aware, patients will always ask this, is when you give these devices and you move your jaw forward, they always ask, is this called jaw pain or muscle pain? And my answer is typically, yes, it does, but with proper management, you would never experience it. So a lot of times, what we do is whenever I'm measuring the device, I'm checking how far they can protrude their mouth and then reach through. I record that and I calculate an average. Based on the studies and literature, 50% is our number that we want to reach. Don't go above 75%, then the oral surgeons start hating us. So that's kind of our measurements. And then when we do that, I also want to make sure that they don't have any TMD or myofascial pain. We can always treat it, but then that's one of those more difficult patients that I have to evaluate, okay? A lot of times when you're doing these testings, you want to go behind them. Always ask for permission, especially if you're of the opposite gender. You always want to ask, with your permission, I'm going to be doing my head and neck exam. Is it okay if I touch your head and neck as part of my exam?
Sure.
Okay. Something I learned in the military, so this is one thing I always do with all my patients. So go ahead and lean back. I want you to go ahead and open your mouth. Close. Open. Close. Do you have any pain or discomfort when I put pressure right there?
Yes.
Okay. Which side?
Both sides.
Both sides, okay. And then you always want to have objective values. So then from 1 to 10, what is the pain level when I put that pressure?
About 3.
3 out of 10. I hear a little bit of clicking on the left side.
Correct.
Typically, when I'm putting pressure, the rule of thumb is about 8 pounds of pressure. So a lot of times what I would do so patients can distinguish the two, you put about 8 pounds of pressure here, they will understand that's normal. Anything beyond that, they will let you know if it's more extreme, okay? So you'll put that in your document, write down your documentation, your paperwork. It's very important to put it in the paperwork because now you have a baseline. They do have some jaw discomfort. You gotta be careful how much you protrude the jaw. Next thing you wanna do, you wanna kind of test the facial muscles. So go ahead and clench your teeth. There you go. So you see the area that it bulges. So what I want to do is, okay, go ahead and relax. I'm going to put that 8 pounds of pressure. Start on one side. And I'm going to start on the right side. Do you feel any discomfort when I put pressure right here?
Yes.
Okay. From 1 to 10, where would you rate it?
About 2 or 3.
2 or 3. Okay. So the way the masseter works is that's the fattiest part of the masseter. That's exactly where we would address if we were to, let's say, do Botox. But understanding where it attaches is equally important, because some patients, they feel like they have pain down here, thinking it's wisdom teeth, but in reality, it's actually just part of the masseters that they're experiencing. They also sometimes feel pain more elevated up here, and those are just some indicators like, okay, if we treat a masseter, this should improve his kind of quality of life. So that you bring it my way, I evaluate how much Botox I would recommend, and that's kind of one thing that we offer. On the left side, how would you rate your pain level if you had any?
About 4.
Okay, a little more on the left. Okay. Okay. Next, you go up here, the temporalis. Go ahead and clench your teeth and relax. So, do you have any pain or discomfort here?
No.
Okay. Do you ever experience morning headaches when you wake up in the morning?
At times.
Okay. Reason I ask this question is because of just the way oxygen works. If you have oxygen, decrease in oxygen saturation to the brain, it causes, morning headaches until you can acquire more oxygen throughout the day, and it kind of goes away throughout the day. It causes a lot of muscle soreness and discomfort because it's like working out, not giving enough oxygen to rebuild. So you have body soreness. This is also the reason why sleep apnea is directly correlated with other medical conditions. You have hypertension, diabetes. Reason being is if your metabolism decreases because you're not getting that quality sleep, or if the oxygen going to those specific organs is decreased consistently every night, it starts affecting its function and productivity. So that's why we always ask patients if they have high blood pressure. That's why we record their high blood pressure as a baseline, because after treatment is done and we get their apneic events down to 0 or less than 5, then we go ahead and do a new reading, calculate the blood pressure, calculate neck circumference, and that gives us what it is before and after. All right. Now, what I like to do is I like to ask patients, when was the last time you've had your last dental checkup?
3 months ago.
3 months ago. Did your general dentist recommend anything? Did they say you had any cavities or you need any crowns?
No.
Okay, good. Reason we ask this is because we're making these customized devices. So any changes in their occlusion, changes to their bite, we want to make sure they're stable before. That does not mean that we want to delay their treatment for sleep apnea. What we want to do as general dentists that sees patients on a daily basis upstairs, what I want you guys to do is look at the signs, very quickly identify if they might have sleep apnea, and then recommend the sleep study. Recommend the sleep study poses no liability to you. Once they do the sleep study, I will go ahead and take the responsibility, do my proper due diligence, do my examination, and give my recommendation to the patient. That way, when I have my appointment, it's not necessarily initial consultation, but more so of going over the results and then doing my proper assessment whether they're a good candidate or not. So then another thing you want to ask is, do they ever hear ringing in the ears? Or if they have migraines, do they ever feel like there's ringing on either side?
I do. I actually have my left ear is ringing, which I'm lucky that my left ear is ringing because I don't want to sleep on my left side because I don't want to put pressure on my heart. So I sleep on the right side most of the time. So I'm lucky, but whenever I turn to my left side, I hear this ringing ding, 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 ding constantly. And for the longest time, I thought maybe there is some neighbors, like some alarm or something.
Right.
And then I asked my wife, "Do you hear the ringing?" She said, "No, I'm not hearing ringing." She was like, "Are you hearing voices?" I said, "I'm hearing ringing."
Not the voices.
So it is. I do hear ringing in my left ear.
Okay, that's good for documentation's sake, because there is some studies that have shown that having sleep apnea unaddressed can result in tinnitus or the ringing of the ears. So we just want to document it for comprehensive purposes. Okay.